so much, Sandra. First of all, it's Ruth Evans speaking, and I'd like to say a massive thank you to Sandra and the team for setting this up today, and also thank you to everyone who's on the line. I don't know if you've seen, but there's about 20 of us on the phone today, and I just find technology amazing. I'd also like to thank the PICO Institute for supporting us. So without NHS IQ and without PICO, we couldn't have this today. But of course, we also couldn't do it without our PEN Awards winners and finalists, and we'll hear more about those in a moment. Today, this is one of a series of 6, and a very warm welcome, as I said, to everyone. Today we're going to be having 4 excellent speakers. 2 are scene setting, and then 2 will be exploring very specifically their best practice. And in there you will find out why they were shortlisted in the PEN Awards for 2014. At the bottom of every slide, in the bottom left corner, if you are a Twitter fan and if you can tweet and be on a webinar, first I'll be impressed, but secondly, there are the hashtags for you. So with each of the speakers, you'll see their own hashtags, but for the whole webinar series, you can see the hashtags there. So what we're going to cover very specifically today are the welcome and introduction that I've just taken you through. I'm going to just give you a tiny taste of some winning principles that we've identified through working with our winners and finalists and the overarching framework for those. But then very quickly we'll be moving on to Bridget from the PICO Institute Europe, who will give us a little bit of insight into what the PICO Institute are up to at the moment. And then we'll hand over to Andrew Hassler from NHS IQ. After those 2 speakers, if we have the time, I'd like to open up the opportunity for questions of those 2 speakers, because I'm sure they all have some great questions to put forward. Then we'll move on to Jimmy and to Alan, who will share their best practice. And both of these won their category, and in fact, Jimmy won the overall category, so they are the overall winner of the PEN Awards in 2014. Finally, we will definitely have questions and open up the opportunity to speak to, well, to ask questions of all of our people, but particularly I'm expecting you'll have questions for Jimmy and Alan about how they made it work and what you might want to learn from them to take forward. So that's the outline. We're absolutely going to be finishing at 1 o'clock today, so lunch, if it's beckoning, it'll be at 1. So I've mentioned the PEN Awards, and I thought it really should, for those of you who haven't been involved in the PEN Awards, I should perhaps tell you a tiny bit about this. These have been going for 5 years, and we set ourselves up fundamentally to recognise and share good practice, things that are working well, and give organisations the opportunity to celebrate that. It's almost a chance to balance the conversation. There's a lot of very negative press about what's not working well, and obviously that's a big issue and it needs to be addressed. But we're equally profoundly aware that there are some brilliant things happening every day out there, and we wanted to give the organisations doing that work the opportunity to shine and to have their teams recognised and to celebrate that great work. So that's the principle behind the PEN Awards. Over the years, and we've been running for 5 years, we have hundreds of examples of good or great practice. And in this webinar series, we are giving the opportunity to our shortlisted organisations in 2014 the opportunity to share their best practice to a wider audience. So enough of the PEN Awards. What we have discovered through the awards are some winning principles. So we took some time in the last couple of months since the last awards in March to talk to many of our winners and finalists but certainly last year and previous years, to try and unpick what makes them winning. What are the principles that allow them to succeed? And there are no big surprises here, and they fall into 3 clusters. The first is intention and outlook, and it's all around having passion and determination. It's around having the opportunity to help organisations both within and without to broaden perspectives, and it's profoundly and fundamentally making it simple. When you look at some of the examples that you're going to hear and also have on our website, at the heart of them are making some of the concepts simple, easy to understand and accessible. The next theme is around organisational support. Organisations who've kind of risen to the top with the awards have had organisational support. In the majority of cases, it's not true in every single case, but where you see consistent organisations doing well in the awards, they have the culture where people are engaged in patient experience and understand the role they have. They have managers who can enable the success, and then they have the leadership who will be able to give the recognition and empower the staff. And then the third theme that we see through the winners in the winning principles is that they have worked hard to give evidence and impact. They can demonstrate the impact. So often that's financial, although not always, but it's also around having the impact of building professional relationships and spreading and getting that reach, and then being able to continue to spread and sustain. There is a whole report about the winning principles which will be up on the website soon, but I wanted to share those with you because they are the themes that we are building this set of webinars against. And today is very much around broadening perspectives. So as I invite the next speakers to hand over to the next speakers, it'll be from the perspective of broadening perspectives. And in essence, all of the winners demonstrate some or all of these principles. But today we're very much focusing on how do we broaden the perspective and how do we understand what our speakers have to share from that perspective. With that in mind, I'm going to hand over to Bridget. And Bridget is the Director of Health Experiences at the PIC Institute Europe. And Bridget, over to you.
Thank you, Ruth. Well, we're really excited about the partnership with PEN and looking forward to seeing the relationship go from strength to strength. I'm going to talk about the work of the PECO Institute and specifically talk about measuring and improving patient experience for all. And it's really the all that I want to focus on, so how to reach out to different patient groups, ensure that their healthcare needs and preferences are really being met. I'll start by giving you a very brief overview as to who we are, for those of you who are not familiar with the PECO Institute, and then I'm going to look at what is patient experience, how do we measure it effectively to ensure that all are included, and then finish with a few real-life examples of where it's worked and where it's making a difference. So the PIC Institute are a not-for-profit healthcare research organisation, and we're committed to making patients' views count in healthcare to ensure the highest quality health and social care for all. Our mission statement is to influence policy and practice to ensure that care is truly person-centred, to inspire the delivery of the highest quality care by developing tools to allow all experiences to be better understood, and that's what we're going to focus on today. And finally, to empower healthcare professionals to make a difference by acting upon this feedback, and we've got some real case studies to share with you. We've been around for about 15 years, and during that time we've gained feedback from well over 3 million patients, probably a lot more than that by now, so we've got a pretty good insight into what patients think. The foundations of what we do are based on the PIC Principles of Care, which are 8 guiding principles that stem from work conducted in the US, and it's all about what is important to patients. I'm not going to go through them in detail, but they're essentially about access, involvement, emotional support, continuity of care, so that kind of underpins all our work. You can see here some of the partners and customers that we work with. So there are lots of partners in the NHS, in the voluntary sector, and government bodies such as Department of Health and NHS England. We also work with a number of voluntary sector organisations such as Motor Neuron Disease Association, Meningitis Now, Young Minds, and we'll talk through some examples of the work we've done there later on. But before we talk about how to measure patient experience, we really need to think about actually what is it. Patient experience is a healthcare buzzword, but to improve it we really need to understand what it is. First, it's one of the 3 key components that make up quality in healthcare, the others being clinical effectiveness and patient safety. And it can be defined as what actually happens to patients as people in the process of receiving care and treatment. So to put it simply, it's the sum total of all the interactions a patient has whilst using a healthcare service. So less about the clinical care, more about the feelings, the interactions, the emotions during that patient journey. But to give a more tangible example, this to me is patient experience. This has come from one of our children's surveys. For those of you, hopefully you can read that, but it says, some doctors didn't examine us, then they shouted, they sent us back home. When we came back, they sent us to the hospital GP. The GP shouted and said, go to your own GP. Then our own GP shouted at us, and we didn't know what to do. So that, to me, encapsulates what patient experience is. It's obviously not a good patient experience, and it sort of shows everything that was wrong about that experience for that child. So why do we need to measure patient experience? In the words of Lord Kelvin, to measure it is to know it, and if you cannot measure it, you cannot improve it. So we need to listen and act upon the patient voice to bring about real improvements that will make a difference. Patient experience is also core to an organisation's reputation and productivity. Obviously, you just have to look at the mistakes at mid-staff to see the importance of that. It's a risk management issue, a key indicator of quality and safety, but seen in a more positive light, so not just a stick to beat people with, but more of a carrot as well. It's an opportunity to find out what patients think and how you can really make their experience as good as possible. To go about measuring it, I could do a whole talk on how to develop patient-reported experience measures, but for the purpose of today, there's just 4 key principles to remember. First of all, you need to ensure that there's patient involvement throughout the survey design process, and that's usually through qualitative work with the target group. The survey needs to be designed by them, for them, focus on the priorities for the group, and understand what really matters to them. Essentially, there's no point measuring it if it's not important or relevant to their experience. Secondly, when designing questions, we always use experience questions, not satisfaction. There's lots of limitations to satisfaction questions, but the main one being that they don't actually help to identify the cause of the dissatisfaction. So we very much ask about what happened during the process. Thoroughly test it with the target group using a process called cognitive interviewing. That's to make sure that they're understanding what's being asked of them. And also, it's very important to choose the most appropriate method of data collection, which best suits the needs of the group. And the most important thing to remember is that one size doesn't fit all. Different patient groups will have different priorities. And this diagram just illustrates our survey design process. So in the Health Experiences team at PECO Institute, we specialise in gathering healthcare experience feedback from the lesser heard and some of the more vulnerable patient groups that may not otherwise have a say. These groups can include children and young people, the elderly, those with learning disabilities, chronic conditions, people accessing children and adult mental health services, and even starting to do some work in prison healthcare. They'll have different experiences, different priorities, as you can imagine, so any PREMs that emerge will be quite different to reflect these priorities. And here's just a few examples of some of the things we've developed. This is some of our work for children and young people, and for those with learning disabilities, our learning disabilities inpatient survey. So they're very much tailored in terms of design as well to the patient group. So I thought it'd be useful just to look at a few real examples of how we've designed PREMs with certain patient groups. And we'll start by looking at the design of the survey for those with a chronic health condition, in this case sickle cell disease. By undertaking condition-specific surveys, we can explore what it's like living with their condition, what are their specific healthcare needs, and what their views and experience of the healthcare. So this research project was undertaken in collaboration with the North West London clerk, and we explore these issues amongst the sickle cell population. And the aim was to develop a set of tools to meet the needs of adults and children with the disease, as well as their parents and carers. So after the focus group stage, it revealed that there were a number of issues, mainly around access to and inconsistency with the quality of primary care, emergency care and psychology services for this group. Also, age-appropriate information and transition to adult services also was highlighted as needing improvement. But one of the key issues that came out was that there was limited understanding of the condition across society, so that there was a real need for increased awareness. The 3 surveys that were developed are currently being piloted nationwide, and it's hoped that eventually the surveys will help to understand sickle cell disease care experiences on a national scale. and inform the delivery, design and commissioning of sickle cell services nationwide. A few more examples of where sort of measuring and understanding patient experience of specific groups has really made an impact. And these are two examples from the voluntary sector. We undertook 2 large studies with the Motor Neuron Disease Association, and this research has fed into their end-of-life guide, which this month we just heard the great news that it's been awarded the Patient Information Resource of the Year by the BMA, so that's really good news. And the guide was produced using findings from a range of studies, including our 2 pieces of research. The first piece was a qualitative piece exploring end-of-life choices, and the second piece was a tracker survey, which was entitled Improving MND Care, measuring people's experiences quantitatively. And overall, the tracker study was the largest of its kind in the UK, and represented the first time that the MND Association's entire membership were given the opportunity to have their say around end-of-life decisions. Similarly, in 2012, we did a project with the Meningitis Trust, now called Meningitis Now, to explore experiences of viral meningitis and its side effects. And the survey findings were quite striking, and they led to them actually starting at the first ever Viral Meningitis Week, which is now an annual event to raise awareness. Another sort of good example of where our work has made a difference. I work with Sheffield Children's Hospital. They've been sort of key partners for our children and young people work over the years, and they've been running our paediatric inpatient and outpatient surveys for the past 7 years. And they're a fantastic example of how trusts can use the surveys year on year to measure experiences, implement changes, and then actually monitor the success of those projects. They've recently undergone a capital building programme, and that's been informed by the survey findings, and it's taken into account things like signposting, car parking, disabled access, and those have been taken into account, as well as parent accommodation needs. They've got a very transparent approach to sharing their findings as well, and their action plans with trust staff and patients, and the action plan is publicly available on the website. It highlights where they weren't doing so well and what they intend to do about it. And it will monitor the scores every year. And this approach has led to a year-on-year improvement in areas like communication, particularly around things like operations. And they've got very specific examples of how they've done that, and that's all on their website. And also looking at the children and young people work, our National Inpatient Survey, which was developed by us, has now been incorporated into the CQC National Survey Programme from 2014, and we're hoping it's going to be an annual survey. And finally, I just want to introduce you to one of our latest improvement programmes, which is currently on the 2nd phase of piloting, which is Always Events. Always Events were first developed in the USA by the PICO Institute. They're an improvement programme that support the delivery of person and family-centred care. So that's patients, service users, families and healthcare professionals working together to co-design care. And for clarity, they're not just the opposite of never events, because never events tend to focus more on breaches of patient safety and professional standards. So always events can be defined as aspects of the patient and family experience that should always occur when patients interact with healthcare professionals. And the processes and behaviours which help to make up a good patient experience, because patients feel safe, involved and well cared for. They need to be evidence-based, measurable and, of course, affordable as well. So they need to be able to be achieved without substantial capital expense. So we undertook the first pilot this year with 3 kind of pioneer sites. And the aim was that to look at adapting the Always Events programme to make it functional in a UK context. And then a toolkit was drawn up to guide providers through the process. And just to sort of put it in a more realistic light, to look at one of the pilot sites was Lancashire Care, and their Always event that they chose was I will always feel supported when moving on in care, as there were some issues around communication when transitioning to different parts of the service. So that was one of the areas they chose to focus on. And they came up with practical solutions, including things like a new format for letters, which are now in use for all patients leaving or transitioning within the service, a contact card designed by service users, and what they call pop-in and chat sessions to discuss the experience. These changes are being evaluated during a follow-up phone call using measurement questions adapted from PICO survey questions in consultation with service users. And it's envisaged that hopefully the outputs can be adapted and tested for other populations within Lancashire Care, including their mental health services. So a further 7 pilot sites have been recruited for the second phase of the project, and that's due to kick off in October and November. And sites are encouraged to share their learning with one another, particularly sites that are focused on similar issues. So I hope that's given you a flavour of the work we do anyway. I'm aware it was a very whistle-stop tour of all the work that we do, but hopefully it helps to show how co-design with patients is essential in order to bring back high-quality, person-centred care. If there are any questions about any of the work that we do or specific projects, then I'll try and answer them as best I can.
Brilliant. Thank you very much, Bridget, for setting the scene and getting us going. Really interesting to hear about some of the real examples of PREMS and the impact the improvement programmes can make, which gives us a great opportunity to introduce Andrew Hassler, Senior Improvement Manager from NHS IQ, who will share some of the latest news about what they're doing to improve the patient experience. Andrew.
Okay, well, thank you for the opportunity to say a few words there about some of the work that NHS IQ is involved with. And what I want to talk about is something called, you may have heard it referred to as PCOMs. The old format was patient-centered outcome measures. And I think outcomes are probably a part of experience, or an experience part of outcomes. In some ways, we're having a bit of a tussle to understand what we mean by person-centered outcomes. But IQ have been asked by NHS England to lead a piece of work to look at, and I suppose it's an exploration, and what I want to do today is to begin some of the conversation around person-centered outcomes. We were originally asked if we could just create a new PCOM, a new metric, and our response to that was, well, we probably could, but we're not sure that's the right thing to do. What we'd rather do is do some work around, and we've kept the M, as you can see, we've multiplied them to 4, but we felt there was a piece of work to try and map what already exists around person-centeredness and person-centered outcomes out there, understand what's already around. Once we've got a sense of that, and that will link a whole host of things around PCOMs and PREMs and PROMs and I think every other 4-letter word that there is around outcomes. Once we understand that, we can then start looking at some modelling to say how it all fits together. Can we create perhaps a framework of outcomes that could be consistently applied across the health and care system? And it's once we've got some sort of framework in place, then we believe we're in a position that we can start to look at what would be the right measures to be able to look at how well we are achieving our outcomes. So what would be the measures of success in delivering those outcome areas? And once we've done some prototyping and testing of some measures, we think we're then going to be in a position to say, how do we make this part of the mainstream? How do we support commissioners to take some of the outcomes framework and the measures and to use the data and the rich intelligence that can come from that to shape the way that services are designed and delivered and improved for and on behalf of patients and carers. I hope that makes some sense. So our strapline is really about saying it's understanding what really matters, which is what counts for people. And in some ways, what our thinking was derived, I guess, in some ways from the statement in the 5-year forward view from National Voices, which was it's about life goals. It's about those things that are important to people. It's not just about getting better or feeling well. Health and care are perhaps an enabler to some of those life goals, but we need to understand what some of those life goals or those outcomes are to really be able to understand how do we design and shape services to meet people's needs in the best possible way. And in saying all of that, I guess there are 3 levels at which we're looking at this work. We absolutely have to be focused on what is important to the person. They're the individual, it's the centre of what's going on. So it's got to be about their quality of life, the things that are most important to them. But for this piece of work to be really successful, and particularly in the eyes of our commissioners, we've got to start to be able to interpret some of that understanding on a personal level at a population level. How can we take information around individuals collectively and say, this is how a CCG or a health and wellbeing board can start to understand what's going on in their community and therefore how they need to shape services. Once we've done that, we think the next stage is then, and perhaps a little ambitious you might think, but is to say, how can we start leveraging some influence over the whole health and social care local government system to look at how services are best deployed to give and to enable the best possible outcomes, not just for local populations, but for the population at large nationally. Now, that is somewhat ambitious, but we're hopeful that we'll be able to make some headway, at least with the first couple of stages there. In terms of the deliverables, the things that we are going to deliver on the ground to show that we've done some work and made a difference, there's a list of them here. We've inherited a set of 8 Pathfinder sites that are all doing some fantastic experimentation work around what person-centered outcome measures might be and how they can work. And we're using that rich learning to inform how we shape our way forward. We held a learning exchange just the other week for the 8 sites, and there is some information around that available, and there will be some feedback. So if people are interested, you can catch up with some of that content on the NHSIQ website. We're also doing an evidence scan, which is that bit about mapping what already exists. So literature review, lots of research to try and establish what are the really great models and frameworks and outcomes that exist out there. We don't want to reinvent the wheel. That's the last thing we want to do. But we do want to understand the terrain within which we're working. And I'll share with you shortly the evidence scan key line of inquiry question that we're looking for, because you may have got some answers and you may have some ideas that can support some of that journey. We think it's important to have some definition around person-centered outcomes. I think if you talk to a dozen people about PCOMs, you get a dozen different responses about what they might be. And we're clear that there needs to be some consistency of understanding so that we can make sure we have that consistent application across different service types and so that we're all talking the same language. So we're going to offer some form of definition during this year. We're co-hosting or co-designing a summit roundtable, so bringing the experts around outcomes, whether that's PREMS or PREMS or PCOMs or other things, we bring them all together in a reasonably small setting to be able to out all the conversation out. What are the crucial parts of those different ways of working? What are the commonalities? How might they work together? Is there something new we need to develop? So we're co-designing that session with the Health Foundation, and that will be taking place in December. Following the session and the findings and the learning from that December event, IQ will be looking to roll out a series of regional events so we can take some of that learning out into the communities and try and find out, is that what works for people? So we're going to try and keep that conversation alive and keep it bubbling up, because the best way that we can get the results around what are person-centered outcomes is, I think, as Bridget was saying, which is about co-creating the answers with people out there. That's absolutely what we want to do. When we've got lots of this learning, we'll produce some sort of publications, both for providers and commissioners, so that we can embed that consistent thinking and way of working, so that we are all singing from the same hymn sheet. And towards the end of the year, the proposition is that we will hopefully bring together a framework or a model that says this is what PCOMs are, this is how they fit together with PREMS and POMs and other things, and that there is some harmony between those things, and that we need to work together to make sure that we've got a sort of a single focus, which is certainly the person-centeredness and how we measure, monitor and support that going forward. We'll also look at a series of PCOMs case studies, and so if people have got ideas for where those case studies might already exist or how they might develop, then we're always willing to hear ideas. We want to try and capture some of that rich learning as we go forward. And there's some deliberation at the moment about whether we will host what we're calling, sounds rather grand, doesn't it, but an international conference. We understand that there's some great work going on in the States and Canada, even Japan, Australia, Sweden, and we want to bring the learning from other players around the world to bear in terms of how we shape our work going forward. So the idea is that we will bring everybody together in one space that enables that conversation to understand how PCOMs can shape up, how it can move forward, and what perhaps year 2 and 3 of a piece of work around PCOMs might look like, which could be into a piloting phase and testing with services. So those are the deliverables that IQ are working to at the moment. I said I'd share with you the key question from the evidence scan, and in some ways this is the nub of what this work is all around. You can read it on the screen there, but it is about making that link between person-centeredness and how we inform and support commissioning to deliver the right shape and style of services to meet individuals' needs and their health and well-being. And my last slide is simply to say we are hosting a tweet chat a week tomorrow, Wednesday the 7th, 20-30 hours. Please join us. We've already got some profile out there, and there's a blog about that tweet chat on our website. Join the tweet chat if you can, offer your views and ideas, and let's keep this conversation going. Many thanks indeed for your time.
Brilliant. Thank you so much, Andrew. And really great to hear, kind of in the moment, what's happening with PCOMs. I can see that people do have some questions, but what I'm going to suggest is if you put the questions through on the chat or indeed the Q&A, we will listen to Jimmy and Alan first, and then we'll take all the questions at the end. But please start to put those questions in. I can see a couple have come through already, and we will do everything we can to answer all of the questions, and if we can't, we'll just brief you on how we'll address those questions at the end. But we are at the point where I think we would really like to hear about what Jimmy's been up to, and also what Alan's been up to. So what I'd like to do is introduce Jimmy, who is from the Leicestershire Partnership NHS Trust. We know he's on the line because we heard his dulcet tones earlier on. And the reason I'm really delighted that Jimmy's joined us today is because they were the overall winner of PENA 2014, an incredibly worthy winner. And to just put that into context, it is the judges vote independently in isolation, and then the people who participate on the day also vote. And Jimmy and his work came out as the overall winner. So we're really, really lucky to have Jimmy on the phone today. And with that, I'd like to just hand over to Jimmy. Jimmy.
Oh, thank you, Ruth, and thank you, Pen, for inviting me to speak about our project. So my role is at Leicestershire Partnership NHS Trust, and my job is about facilitating use of mobile media in community health services. And at the time that we were involved in last year's PEN Awards, my post was funded through sort of begged money, really, begged and borrowed money, bits of funding pots from here and there. So I'm going to talk about Chat Health, our school nurse messaging service, which is a project that I work on. And my job, I work a lot with school nurses, and consequently I work a lot with young people. And as we know, young people are sort of leading a communications revolution, and I think we're probably also aware that in the NHS we lag behind that a little bit. So that brings me to quiz time, and I've got a slide now. It's got a photograph of two mobile devices, and I'd like you to identify which of these belongs to a 14-year-old young person in school and which one belongs to an NHS member of staff. So there you go. Hopefully it's quite clear to you which is which, because you probably know that sort of 80% of young people in secondary schools own smartphone devices like the one on the left, and 100% nearly of all kids owned at least some sort of mobile device like the two that you can see on screen. And the amount of time that we spend talking on the phone these days is in decline for the first time ever, which is quite a remarkable thing, really. And that's because of our movement towards using messaging to communicate with one another. And they reckon the average teenager sends about 3,000 messages in a month. So in that context, in that landscape, we set a patient experience ambition, and that was to transform access to healthcare for young people that are part of this smartphone generation. And what the world looked like for them before we began this work is that they might wait for a week for a face-to-face clinic to be able to come and speak to a nurse about something they were concerned about. And this in a world where they're used to shopping online, instant communication with friends and family. They might have to ask a teacher's permission to come and see a nurse, or attend a clinic that was being held in the office opposite the headmaster's room. So kids were asking for a visible, accessible and confidential school nursing service, and we weren't really giving that to them. Certainly, you know, like from a sort of confidentiality point of view, there was something about the geography of being in school and having to see a school nurse in school. And we knew from unpicking the research that when they said visible and accessible, they didn't necessarily mean in school. They just meant that we need to know that a nurse is there when we want to reach one. And so we wanted to respond to that feedback and give young people age-appropriate access to healthcare. And actually, I felt that if we failed to do that in this environment, young people would disengage from healthcare, and underserved young people would become increasingly marginalised. And here's an example of one of those young people. This is Freddie, a young man that we did some engagement work with. So when I first met Freddie, he was 17, he was at school in Leicester, quite low self-confidence really, a shy bloke. His self-esteem was pretty low. He was very closed off about speaking to adults, and he was actually suffering from anxiety and depression. And at that point, that was becoming quite impactful on his life experience, but he was also suffering in silence, and in that he typifies many young men. Now, we know that young people like Freddie were prolifically using text messaging and prolifically owned devices. So we knew that text messaging could be a route to improve healthcare for people like Freddie, but what stopped us doing it so far, I guess it was the vulnerability of teenagers, you know, with increasing sort of depression and self-harm rates. We knew that there was going to be some risky content in those messages, and we wanted to mitigate that safely. So we wanted to proceed, and we could see the benefits, but we could also see the dangers, and they were particularly around vulnerable young people trying to contact us out of hours when nurses actually weren't there to respond or support them. So we asked a number of different organisations that were involved in safeguarding young people how they felt we might deliver on this and meet our patient experience ambition. And particularly we asked school nurses and young people, and they helped us to solve the problem, particularly the young people, because they don't see any barriers at all. So the kids said, why don't we send messages just as we would normally do, but why don't you land them in some sort of computer-based risk management system, which is what is depicted right in the middle of the screen. And that risk management system can respond to messages that are sent out of hours when nurses aren't around, and you can signpost it to other sources of support. So that's depicted bottom left. It can interface with your patient record, which is depicted bottom right, and in that way everything will be auditable. But significantly, why don't you let all your nurses be able to access and manage messages with young people as a team? And why don't you have the messaging system notify nurses when key things need to happen, make life easy for nurses? And that sounded great to us. We just couldn't find a system like this off the shelf, and so we began developing it ourselves, and we've now done that, and we call the product Chat Health. So Chat Health is a sort of an internet-based message management system for frontline staff to use with service users, and they can use it on laptops or mobile devices, and it looks a little bit like webmail, but they're managing messaging with young people. So what's the impact on the patient experience? Well, firstly, it's safer, because alongside the technology we developed some guidance for nurses that was really comprehensive and sort of outstripped any other guidance that was available about messaging to date. And our emphasis in that guidance was really on risk of harm, and unfortunately, you know, we've had to put that guidance to the test quite a few times when we receive the kind of messages that indicate a young person's at risk of harm, and that's imminent. So I've got a few examples of how we've safeguarded young people, and we always seek feedback after those sorts of experiences. So I've got a sense of how the young people feel about the way that we support them. Probably too little time today to get into that, but the evidence is there in sort of supporting the practice around that. Is it just about improving safety? I think there's probably something that's about improving choice for young people. So young people like these tell us they sometimes feel more confident or more comfortable if they can talk about difficult or sensitive issues sort of remotely or anonymously. And they use this phrase, behind the screen, you know, the idea that they can hide behind the screen. Of course, they mean the screen of their mobile device. And the nurses that are using messaging with young people say they speak with more young people across a broader range of issues than they used to do. And 5 out of 10 of our messaging service users are male. And we know that young males like Freddie are typically less likely to engage with healthcare. It was more like 1 in 10 in our face-to-face clinics. So I guess that brings me back to Freddie. Of course, you've probably guessed by now that when we met Freddie is when he began using the messaging service, and that's when he first engaged with healthcare. So I'd like to think that we've empowered young people like Freddie to take more ownership of their health outcomes in terms of their patient experience. I think when we talk about patient experience, it's always worth having a quick look at the staff experience, and the feedback. This is Tracy, one of our school nurses. The feedback from staff is excellent. She looks particularly happy because one of the outcomes is that it's not really more work for Tracy, and she's already pretty busy. There are only 1,200 school nurses across the UK supporting 20,000 schools, so they need more sustainable models of being able to support more patients. And here in Leicestershire, the school nurse messaging service supports 65,000 kids, yet we only have one nurse sort of triaging what comes in from those 11 to 19-year-olds. We intervene earlier. And by the way, that sounds horrific, but it's actually manageable, which is why Tracy looks pleased. You know, the sort of staff to patients ratio stacked up really well from a staff point of view. We intervene earlier, which is an improved outcome for patients, and we triage less up the tree. So a lot of stuff is dealt with purely as text messaging. So we're kind of releasing time to care. And our face-to-face care is reserved for where it will most make a difference. They delivered about 1,000 additional contacts last year through using messaging, and if we'd have been working to more traditional models, we would have required another 2 nurses really to deliver those contacts face to face, whereas this, we just fitted it in within existing capacity. So it's good for patients, but I guess it's also better for taxpayers, better for nurses, and obviously better for young people. I'm going to start wrapping up now. I just want to quickly talk about dissemination, really. I mean, we've always been quite passionate about this work, and we've always been active on Twitter, you know, sharing our learning and connecting with that community of people that share our interests. What we discovered is there was a healthy appetite to adopt this practice. People didn't really want to reinvent the wheel. So we looked at a program. This is all since winning the PEN award last year. We introduced a program whereby we package up the service that we developed, and we provide it into other organisations that want to work in this way. And we've received some funding from the Academic Health Science Network and NHS England to do that. So we can effectively do this in a really cost-effective way for these organisations. So currently we've got, in the last 6 months, we've joined forces with 10 other NHS trusts that are now working in this way. So the service is not just in Leicestershire now, it's sort of in different locations across the UK, which we're really delighted about, and we continue to do that. And we were really well supported by our own organisation in doing this, you know, right up to our chief exec. And I think that comes back to Ruth's earlier point. So the next year for us will be about trying to meet up to this agenda of diffusion at scale and pace. And we're you know, talking to about 80 different organisations actually that have expressed an interest in working in this way. And if you're working in an organisation that you think might be interested, that's my Twitter handle, and the Chat Health Twitter handle there, and you can contact us. So is it definitely working? We did measure what we do in Leicestershire and spoke to patients about their experience. We did a survey of about 2,000 respondents. We did some patient and staff satisfaction video interviews. We did a mystery shopper exercise, which was great. And we had a staff reference group where staff peer reviewed a load of conversation transcripts, and their conclusion was, through all of this, was that Chat Health provided a thorough, timely, instant, informative, succinct, safe, non-judgmental, sensitive and reassuring health service for young people. But the final word should go to some of the patients that we support. So you can see there are a couple of comments from the patients that have used the service by way of closing. So thanks again, Pen, and thanks again, Ruth.
Thank you, Jimmy, and thank you for keeping that to just 10 minutes. So a lot of content there. If you do have questions for Jimmy, please send them through. We are still hoping we're going to have 5 minutes at the end, but that will all depend on Alan. And I'd like to introduce Alan Anderson, who is going to be our final speaker this morning, well, actually this afternoon. Alan So Jimmy won the overall, he was the overall winner, but the category they entered was innovative use of technology. This category that Alan entered was personalisation of care, and they were the winner of their category. And on that note, I'd like to hand over to Alan to take us through their work.
Thanks very much, Ruth, and no pressure. So I'll race through the presentation. I do have to say a huge thank you to Annie Gilbert, who was the researcher for most of this work. Unfortunately, she can't be with us today. But what I want to just talk about is just to give some background to Positively UK. So we are a charity. We've been running for just under 30 years. We were founded by 2 women living with HIV. So this idea of peer support and the ethos of peer support is very much embedded within the organisation. We're medium-sized, 19 members of staff. We have a very strong volunteer programme. All our frontline staff and volunteers are also people living with HIV. And we very much view health not just about that physical, it is about the emotional and mental well-being. And we know that within people living with HIV, for instance, there are higher levels of poor mental health, but also that social side. And for many people, stigmatising conditions such as HIV does lead to a lot of social isolation. So our work is very much supporting people with HIV, managing a new diagnosis, managing any aspect of their health and well-being. And to do that, we do work collaboratively across the NHS. We provide outreach across 11 clinics, very much integrated as part of the interdisciplinary teams within those centres. So what we wanted to do within our research programme, we wanted to look at how we complemented things and worked within the NHS outcomes framework. So we looked at domain 2, which was about enhancing the quality of life for people with long-term conditions. We also looked at the public health outcomes framework, which does look at improving health and mental well-being. And I think it's interesting that since we've actually published the report, we've had the publication of the NHS 5-year view, which talks about encouraging peer-to-peer communities. So the evaluation project, we wanted to see what impact we had on well-being. We wanted to see what perception service users had of the service, how we complemented clinical care, and what aspect it had on, what impact it had on other aspects of life. So we had 137 responses to a survey, and 70% were female. We were started as Positively Women, so this is quite what we expected. I think if we were to take this research now, we'd actually find a much more even split between men and women. Average length of time with HIV was over 11 years, so some people living quite long term with the condition. High percentage of people from heterosexual communities, Black African and Black Caribbean communities. Overall, I have to say that people were extremely satisfied with the support they received. A couple of quotes I'm going to pull out of there. It's the first one. It says that I feel I am not alone. And I did mention the social isolation that people feel. So that's really a crucial area for us, that people do feel part of the community, that they do feel they have someone to talk to. The other one is this quote, professional, caring and knowledgeable. And I think sometimes when we talk about peer support, it can mean a range of different approaches, if you like. But what we have is staff who are trained up to level 3 in advice and guidance. We also have a robust training program for our volunteers where they all receive training and an NVQ level 2 in mentoring. So it's really about how that lay-led service does, have that professional approach. So moving on to the survey itself. So we wanted to look at how peer support affects, different aspects of living with HIV and how it complemented the clinical care. So we asked a series of questions around, does it improve understanding of management of HIV? Does it help access other services? And we asked people to rate on a scale from it supported not at all or supported all the time. So we found that there were top marks around improving emotional well-being, 90%, also around understanding and management of HIV, and also helping people to access the services they needed. And I think that, again, that's one to highlight, because it's not about just us delivering all aspects of support. It's about understanding who is best to access that, provide that support, making sure that people are accessing that and able to navigate what is really a complex and quite confusing health and social care system. Just to say, we did also do later on a survey of clinicians who we work with, and we found that 100% of them also agreed that we complemented clinical care, that we improved the understanding of patients living with HIV, and that as a result of our support, they felt there was actually better dialogue between them and their patients, and the patients were able to talk to their HIV healthcare providers. The second aspect we looked at in terms of the public health outcomes was the Edinburgh-Warwick Wellbeing Scale. Now, this is within the public health outcomes framework. It's recommended it's used, but I don't think it is picked up, sadly, by many local authorities. To explain, it has 14 questions that all relate to different aspects of well-being. It rates them on a scale of 1 to 5, and questions include, I've been feeling relaxed, I've been feeling optimistic about the future, I've been feeling good about myself. So the lowest score someone can get is 14, and the highest possible score is 70. So we did this across a range of individuals, asking how they felt before they'd accessed peer support and how they felt afterwards. So what we found was that prior to accessing peer support, we had a range of scores from 14 upwards. When people said they'd finished peer support, scores ranged from 27 to 70. So nobody scored the lowest. Everybody said they had some improvement of mental health or emotional well-being as a result of accessing peer support. Further analysis of this, and we were very excited, probably quite sad, but we were excited when we got this result. So we looked at the Mann-Whitney U test. We wanted to see if this was just a random result or whether it was statistically significant, and we did find out that there was actually a p-value of 0.1, so therefore it is actually a statistically significant piece of research, which I think really demonstrates how peer support can impact in supporting people and their emotional well-being. We asked people how they prefer to access peer support. Now, this might be quite particular to our cohort because this is what we provide, group support and one-to-one support, but definitely this is how people wanted to continue accessing services. And also, in dealing with the cohort we're dealing with, where people do feel isolated, we do find that even moving forward with our gay men's work, with our young people work, there is a real demand for that one-to-one, for that face-to-face support, and for those group and social activities. So to summarise, peer support does improve well-being, it complements clinical care, and it really does have a positive impact on people, the lives of people living with HIV. Now, this is relevant to other groups. We think it can be taken across any groups, and we know Mind, for instance, are using it within mental health. It doesn't matter the size of your group. We started very small, and we're now over 1,000 people. Other organisations could adopt it and can use this research to demonstrate how peer support is useful within the clinic. So just to almost finish off or wind up, so patient-led services are developed and delivered by people living with HIV. These are the key elements of any peer support. They have to be bottom-up. We highlight that it's an undervalued and underfunded service, and quite often what we're finding is that peer support is almost falling in between two stools. It's seen as something that people want to have in the clinic, but it's quite often unsure who should be funding it. And in HIV, there's really this battle between, is it local authorities or is it the NHS who should be funding that? The robust evaluation proved that peer support does help and support long-term condition management, and actually it draws upon the strengths of the voluntary sector. It has a role in supporting clinical care. So my final slide, just to look at where we are now. So we are working with local authorities as they retender over 2015 2015 and 16 about commissioning peer support, and we've tried to make that argument that peer support should be commissioned as an integral support of helping people living with HIV. Now, whether that's funded by local authorities or in clinics, we really don't mind, but it really has to be seen as an essential element of care. We've also been awarded a rather large grant from the Monument Trust. Project 100 over 4 years will see us roll out our peer mentoring program, training up 1,000 people living with HIV in peer mentoring. And to do this, we're working with groups across the country, from small patient groups up in the Highlands to NGOs in Leicester, Bristol, Manchester, and HIV clinics in London and across the UK. Also, as part of that, we want to do a wide-scale evaluation. And what we don't have here is that financial modelling to demonstrate the cost effectiveness of having peer support within the clinic, but also look at the return on investment in training up 1,000 people with HIV. How does that impact upon them and their role as patients, and also the organisations we're working with? So that's the end of my presentation.
Brilliant. Thank you very much, Alan. So 4 amazing speakers, concise, to the point, and on time. Sorry, just to whet your appetite, here's a question, and it's for Bridget. So the question came through: are there any groups of patients or service users that are particularly challenging to gain feedback from?
Well, I think all groups and patients and service users come with their own challenges. It may be in terms of finding them, actually gaining access to speak to them, or actually communicating with them. But sort of in our time, we've sort of looked at quite a broad range of patients, including those sort of elderly with early stage dementia. I mentioned before we're starting some work with prisoners. We've spoken to people living with motor neuron disease, so a terminal illness, about end-of-life choices. We've even done work with children in hospices who are unable to communicate verbally using talking mats and things. So there are ways of accessing these groups. So we like to think that most patients are able to be accessed, as long as you're obviously sensitive to the needs of the group and understand the target group.
Thank you very much, Bridget. Perhaps if you do have questions, if you could send them through to either the Twitter handle that you saw, or if you've got their email details, but as a total fail-safe, send them through to Ruth Evans. You've probably all got my information, r.evans@patientexperiencenetwork.org, and we will make sure those questions are answered for them. So I did want to thank everyone for taking part. I'd like to thank our speakers for being on our inaugural first ever webinar. We're very grateful. I'd like to thank the audience. Please could you spread the word? We had over 20 people in the end join us today, which is amazing, but I think we could do better. And it'd be great if we could have more, and the dates are there, if you could spread the word. But my last thank you is to NHS IQ, to Sandra, and to the PICO Institute for your support. Thank you very much, everyone. Have a good rest of the day.